All right, so we're going to go ahead and get started. We'll start off our morning with some very interesting topics. Social Security. Very interesting. So my name is Lauren, and I work for OMSOS at the Department of Human Services. I oversee our SOAR initiative for the state, or the Commonwealth, and I also oversee a project called Projects for Assistance in Transition from Homelessness, which provides services that traditional Medicaid billable services don't really necessarily provide. So things like street outreach, case management, that allows for more typical or non-typical engagement periods, so things like that. And we are required to let you know that the views in this presentation do not necessarily represent SAMHSA, CMS, yada, yada, yada. There you go. So a little bit about me. That's me. This summer I went to Lady Gaga concert in Las Vegas. I saw her jazz and piano show. It was awesome. So I started off my career, I graduated with my undergrad in 2013. Fall 2013, I was on the 6.5, maybe 7-year plan for college. So it took me a while to figure out what it was I wanted to do. I always knew I wanted to help people, but I wasn't really necessarily sure how. But I landed in sociology. I kind of wanted to end up in the research section, but after graduation, I applied to probably hundreds of jobs, and the first one that I was hired into was actually with Pittsburgh Mercy, Operation Safety Net. They provide street outreach, permanent supportive housing, pretty much wraparound services to individuals experiencing homelessness or at risk of homelessness. So here's some of the work that we did. This is a camp clean out, so trying to keep the peace between the city and while also respecting the dignity of individuals that live there. You'll see a lot of trash. There's no trash pickup when you live in an encampment unless that's coordinated, and eventually we did get to that point, so that's great. This is a picture of our memorial wall. Every year on the longest night of the year, we celebrate. We remember the individuals that passed away on the street. We try to reach out to their family and ask for permission to post a plaque for them, and we try to remember something positive about their lives. And then social worker. I think we're all asked to do more with less all of the time. From my experience, being a direct service provider, I'm a highly sensitive person, so I knew that it was time limited for me. I knew that the vicarious trauma was taking its toll on me, and so eventually I was going to have to kind of take a step back and move into more of a grants management policy position so that I could still help, but also I couldn't do that direct work. So that really kind of was a big transition for me. Experienced a significant number of deaths, all about the same time. Some of them violent, some of them overdoses, but all people I really learned to care about and love. So now I work, after I went with Operation Safety Net, I went to work at Allegheny County Department of Human Services in their Office of Behavioral Health. I oversaw a program that assists youth and families that experience civil unrest after stress and trauma, so gun violence. And then after that, I came to the state, so that's where I am now. So SOAR. Has anybody ever heard of SOAR before? Okay. Is anybody trained? I always get, so I have the list of everyone that's ever started the course, and it's about 14 miles long.
I'm on it.
Yeah. The completion list is like maybe 600 people, so I get it. It's a lot. It's a lot. So SOAR, if you haven't heard of it, it's a model for assisting individuals to apply for Social Security benefits, so either SSI or SSDI. It targets individuals that are at risk of homelessness or currently experiencing homelessness. And we use that at-risk terminology pretty loosely, so not necessarily like the HUD standards where you have to be eminently homeless tomorrow or within the next 14 days. Pretty much our rule of thumb is if you are being subsidized in some way or another, if you're living in Section 8, or if you are low income and you're being supported with case management, if that support went away tomorrow, would you likely be homeless? So that's kind of our model for who we consider to be at risk. It just widens the net, and we understand that this is a very difficult, red tape intensive system we're trying to navigate, so we want to help as many people as we can. It is sponsored by SAMHSA. It is not funded by SAMHSA. So oftentimes whenever I have conversations with communities, it's looking for local funding to fund positions to do the SOAR work, or a lot of times we look at existing services and how we can kind of streamline them to assist in the SOAR model, because they probably already are helping people apply for Social Security benefits, maybe just not in a tracked model thing. SOAR is available in all 50 states and territories. And fun fact, if you are receiving SSI in the contiguous United States, or I guess all of 50 United States, and you go to Puerto Rico, you are no longer eligible for SSI because they don't offer SSI in Puerto Rico. So, Jacqueline. So my connection with SOAR began when I was a caseworker. I worked with an individual, we'll call him John. He was a 34-year-old man living under one of the many bridges in Pittsburgh, severely underweight, schizophrenic, auditory hallucinations, could not hold a conversation, did not trust anyone. And so my position as a program assistant and street outreach worker, I really wanted to make a connection with John and kind of figure out how we can improve his situation. No work history, and if he did have work history, he couldn't verbalize that to us. So when I began working with him, it was a lot of just showing up consistently. Bringing tangibles, here's water. And so through that, he was able to kind of let me in a little bit. And at the time, we had a little bit of a side door to coordinated entry because we did have street outreach and our permanent housing programs within our own agency. And so he had never been assessed because he wasn't, able to answer the questions. So I went to the county and I advocated for him to get into one of our permanent supportive housing programs. I felt the best option would be for him to do site-based, but we all know there's not enough site-based housing available for individuals. So the other option was living in a community in his own apartment, which was going to take intensive supports. And so that's what we did. That was our only option to get him off the street. So we moved him into an apartment, and I visited every single day. And he was getting thinner and thinner and thinner. We had attempted 302, did not go through. And so I remember one day I was able to convince him to let me take him grocery shopping. So we got groceries, we came back to his apartment, and there's a padlock on the door. And I think I'd only been with the agency for maybe 4 months. And so I'm trying to figure out what's going on, why is there a padlock on your door? We paid rent. So I called the landlord, and the landlord says, oh, that guy's crazy, he can't live in my building. And so I'm standing out here with milk, eggs, frozen items, and John. I don't know what to do necessarily. I wasn't prepped for this. So I call my boss, and she says, well, what do you think we should do? I was like, honestly, I feel like I should put her in. And she was like, whatever you do, I support you. And so I think the neighbor downstairs, he was, tight with John upstairs. He got a crowbar, and we broke into the apartment. And so kind of realizing, like, okay, this is helping the issue now, but what's going to happen when I leave? So we got into the apartment, and I noticed that John had a kitten, a little orange kitten, riddled with fleas. And on the floor was a bowl of hot sauce and Cheerios for food and water. He was trying to do the right thing. But I said to myself, this is not going to work. I called my boss back, and I said, what do we do? So we took him to crisis. We get to crisis. John gets out of the car, runs up the street. He's convinced that I'm trying to lock him up. So crisis was not going to work for him either, because he couldn't smoke. He can't come and go and smoke. So he needed something flexible. And on our 3rd floor in our building, we did have a safe haven. Pretty much, we accept you as you are. We don't want you to drink and smoke in our building, but if you show up, blasted, it is what it is. We'll help you to your room and make sure that you're safe. We didn't have any openings. That's where I would have preferred John to go in the beginning. So I asked my boss, if I give up my office, can we put a bed in there? And she was like, so that's what we did. We put John in an office until we could figure out how to get him housed in our safe haven. And there was a significant waiting period, but we saw him every day. I was able to continue to build that relationship. And on the 1st floor of our building, we had a health center. And so talking to John every day, trying to get him to be engaged with this health center. And I came to realize that John was really motivated by money. And so talking to John said, there's a program, I'm sure you've heard of it, Social Security, but you need to kind of establish your medical history. Would you be willing to go and meet the doctor? No meds, because that was off the table. No meds, just meet with the doctor. Get a history going. It'll lead to income. And so the more and more we did that, the more and more we were able to kind of establish that medical history that he really needed. If I had sent him down to the Social Security office and said, apply for Social Security, nobody would have taken the time to do that with him. It just wouldn't have happened. And so we actually had a new SOAR program at It's Mercy, and with me leading the way on the services and SOAR being the understanding all of the Social Security aspects, we were able to put together a complete quality package to Social Security, and John was approved for Social Security. And so eventually he did get his own room in our housing unit, and I would see him every morning. He had a payee, definitely had a payee. He would get his weekly spend checks, and he would go up to the Goodwill, and he would get a cane, just all sorts of things. He'd be like, "This is my drip," and he was so proud of it. And I see him now, even though I don't work downtown Pittsburgh anymore. But he's not medicated, doesn't want meds, but he's stably housed. He's off the street and he's safe. So, yay! That was he still has his income, and just through learning to trust me, he's begun to kind of trust other people around him. So I thought that was really cool. But without SOAR, he would not have income, and he would still be struggling. And he's now on Section 8 too. He doesn't have permanent supportive housing. He has just regular Section 8. And somebody does go visit him regularly because we really like him. Okay, so Social Security, the two different buckets that you apply for, SSI, needs-based. It's for individuals that are low income and low resources. You must have less than $2,000 worth of cash on hand, which I don't have $2,000 worth of cash on hand. So, but that doesn't mean that there's not a ton of technical denials. You are allowed to own one home, but you can't own two. You can own one car, but you can't own two, different things like that. And so a lot of times when people apply for Social Security, they get it wrong. They don't allow for those housing arrangements and allowances. And so I'll show you a chart later, the technical denials list of percentages of approvals. It's ugly. So the benefit rate for Social Security this year is $943. So it's not much, and hardly an apartment. So, and then the date of eligibility is based off of your protected filing date. So that would be the date that you call Social Security and say, I intend to apply for Social Security. And the health insurance that comes with that is Medicaid. The other option is Social Security disability. That is based off of your working credits and your work history within the last 10 years. So if you have somebody that, worked in the mill their whole life, but for the last 20 years hasn't worked, they're probably not going to be eligible for SSDI, unfortunately, even though they have a significant work history. And so the amount that is earned for SSDI is based off of your earnings. It is possible to have both SSDI and SSI, but when that does occur, it's typically you have fewer working credits, and so they're supplementing to get you to the 943 with SSI. SSDI, I think the maximum amount is up to like 3,200. And that is based off of the date of onset of disability. And there is a 5-month waiting period. And with that, you get Medicaid. So Social Security's definition of disability. So it's based off of your medical condition, your diagnosis, the documentation of your diagnosis, how long you've been disabled, and most importantly, how that affects your functioning. So we know that individuals that have bipolar disorder experience significant symptoms, but let's be honest, people that have bipolar disorder go to work every single day. They don't need disability, some people. Some people, their functioning is so severely impacted that they are unable to work, and they are unable to earn what Social Security calls substantial gainful activity, which for 2024 is 1620. It was 1550. That's 2025. 2024 is 1550. It's gone up to 1620 for 2025. So if you are trying to work or unable to work, if you earn more than 1660 in the year 2025, you are ineligible for Social Security. So they're going to find you ineligible right off the rip. But if you earn less and you are trying to apply for Social Security, that's great. You should work if you can work, because even showing that you're trying to work, but you can't manage to earn SGA is great for your application. And so that's like a myth that I always try to dispel to people. So this is the 5-step process that Social Security uses to evaluate adults. And what I always like to point out is how many times you see denial and how many times you see approval. So it's more likely that people are going to be denied than they are to be approved. So at the first step of your application gets sent to Social Security, and they review it for the financial piece. So is this person working at substantial gainful activity? So are they earning more than $1,550 a month? If the answer is yes, they're denied immediately. If the answer is no, then they say, does this person have a severe impairment? If the answer is yes, then they'll move on to, does the impairment meet or equal the listing? So Social Security has a list of, called the Blue Book. It is not the Kelly Blue Book. I do get emails with people that are confused. But So they have a listing of different diagnoses and then the criteria that it would take for someone to be considered disabled. And I'll show you one of those in a little bit. If the answer is yes, most likely it's not, then it gets sent to, does the impairment allow for past relevant work? Probably not. But then what they do is they take this other book from 1991 that has not been amended, called the Dictionary of Occupational Work or something like that. There are jobs in there that have not been relevant. Like I was looking at it yesterday just to have an example, and like handwritten letter writer is one of the options. Just last year they obsoleted that, so that's no longer in consideration. But yeah, so Social Security will look and see, do you have any options to work, even if there's no jobs in that job market? It doesn't matter. If the answer is yes, you'll be denied. So that's why it's really important that when we're submitting medical summary reports and submitting medical records, we look at the entire picture and say, like, this is why the individual is unable to work. I get a lot of emails with individuals with anxiety disorders saying that Social Security suggested to them that they be a Walmart reader or work in a phone call center. And I'm just like, I have an anxiety disorder. Like, I can remember I couldn't answer the phone. So, like, suggesting that it's almost insulting, but that's how it goes. So this is the trend in outcomes of applications. So 40% of your applications, pretty much across the last decade or so, maybe two almost, are denied based off technical denials. So that's going to be maybe the person's making more than $1,550, or their application wasn't submitted correctly, or the person cannot be reached. And so what we know is a lot of our folks don't have stable housing, and they don't have an address to receive mail. And if they do have an address, they do have that luxury of having an address, they can't pick it up often. So getting information from the Social Security office, a lot of times people are just denied because of technicals. And you'll see that the award on initial application is very low. Another thing I thought was interesting is the pending decision is just getting wider and wider, but we actually know that fewer people are actually applying for disability. So I think that is probably the workforce is shrinking to process those applications. And they are trying to put together a strategy to address that at Social Security. So SOAR. This slide is just some of the resources available on the website. We do have both an adult and child course, and we have a bunch of different resources that caseworkers can use to kind of put it through the lens of whatever population that you're working with. So this is really great. The SOAR website it's awesome. Okay. So Social Security, it's not much. $943 is not going to buy someone a car and pay their rent and feed them and, maybe treat themselves once in a while. But what we do know is that it does offer that foundation, just like for John, like I told you earlier. It offers that foundation of something to kind of get you to move in the direction of wellness and recovery. It also brings with it access to healthcare, Medicare and Medicaid. And there are the work incentive programs. Not a lot of people take advantage of those. So if you could start spreading the word about work incentive programs, you're always going to make more if you work when you have Social Security. They're not going to cut your check, and you're never going to get less. It's for every $2, they take more. So you're always going to get more. And it also decreases incarcerations and hospitalizations when people have income. Am I going too fast, talking too fast? Sorry. I'm very nervous. All right. One of the benefits of Social Security is that when a person is approved, the state and locality can actually recoup their costs for things like TANF or any county dollars. The county dollars gets a little sticky because you have to have a formal agreement with that person before you can recoup that dollar from the Social Security Administration. But when it's Medicaid, they do it automatically. So they make it a little harder for localities to recoup those costs. So cash benefits and back payments received by the individual for SOAR alone in 2023 or $717 million was put back into the local economy because of SOAR. And who is a SOAR applicant? So another thing available on the SOAR website is kind of a decision tree. And each location that does operate SOAR likely has a similar referral. They may have a wait list. I'm trying to grow the program. It doesn't cover statewide, and I'll show you where it is prevalent and where we need more work. So does the individual have a disability? Yes or no? Are they experiencing homelessness? Yes. Use the SOAR model in all 5 components. So that's pretty much the only criteria to use the SOAR model. Anyone can do SOAR. You don't have to be a dedicated SOAR caseworker. Like I said, if you are a service coordinator or somebody that just assists individuals with obtaining income, you have access to the SOAR model. You can take the training, it's free, and I'll show you more about that in a minute. But pretty much what it does is it takes all of the breadcrumbs that Social Security gives us to try to navigate their system and puts it all into one model and linear pathway to help people access benefits. So critical components of SOAR, what makes it different? So you use the SSA 1696, which is the equipment and representative form. I can remember my days as a caseworker trying to call about somebody's electric bill that's off, and they won't call, but the electric company won't talk to me. So their electric stays off until I'm able to, connect with them, and then they can be there. But if you fill out this 1696 form, there is no legal obligation. It is just you are their representative. You can call Social Security on their behalf and talk to them about their case. You are able to say, what do you need? What else, do I need to supply to you to be able to get this case approved? You can call and ask for status updates, and you also receive all of the mail that they do. What's up?
I'm sorry, can you read that number again? I can't.
1696? Yeah, SSA 1696. And you can use that even if you're not doing the SOAR model, if the person will sign it. It's just a standard Social Security form. But it does give you the power to be able to, kind of figure out what's going on with the person's case. Because when somebody comes in your office I don't know, you're able to kind of follow up on that. So the onus of collecting and submitting the medical records is on the caseworker in the SOAR model. So getting to know a person, where they've been seen, building that history of treatment, using motivational interviewing, trying to figure out where you need to collect medical records from. A lot of times SOAR caseworkers have really good relationships with the medical records department where they'll actually waive fees for medical records, or they will expedite them if they know it is for a SOAR SSI or SSDI application. It's really about building out your relationships with kind of those primary agencies that a lot of people in your community use. So that really just takes an outreach.
So when you talked about John at the beginning, you didn't have any medical records
Yep.
on him. So they accepted just what you were able to provide.
Yep.
So if we only have a snippet of history of someone, and we provide just that, that is sufficient.
Yep. Yeah, because at the time, he met all of the Blue Book listing for schizophrenia as a disability. And so even just I'm not leading the doctor, but I say to the doc, because they're with our agency, I'm very transparent. I'm trying to get this through Social Security, and he doesn't have medical records. So if you see any of these things, could you put it in his record? So that was just a relationship that I had with our community health worker and community doctors. But I can see how not everybody has that. But if you do have that opportunity, you can just be kind of transparent and say, like, these are the listings. And if you see these, it would be pertinent that you put it in this person's record.
And they accept correctional medical records as well.
Yeah. Yep. Did you have a question?
No, that was my question.
Okay. So writing and submitting a medical summary report, this is actually unique to SOAR. Medical summary report's not the best name for it. It's more like the most intensive case note you'll ever write in your entire life. I'll show you an example and also the different components of it. But what it really does is those gaps in the medical history, it tries to fill those in. So you, as the SOAR caseworker, ask a person about their employment history. How did that go? Were you fired? Did you have any struggles to relating with people? Did you have difficulty showing up? And you put all of that in the medical summary report. That way, whenever Social Security gets to reviewing their application, and we know that a doctor in an inpatient unit is not going to be talking about the person's employment history or their, how they were traumatized as a child. So really providing that full story of an individual and telling Social Security how this person got here and why they really are disabled and how that limits their functioning. Their disability limits their functioning. So,
are they able to have more than one representative? So saying that someone's incarcerated, she would be a prison counselor and I'd be the parole officer, so we can both communicate.
I think they'll only allow for one.
Okay.
On record, yeah. I'm pretty sure they'll only allow for one. But let me get your contact info afterwards, and then I will actually ask. I don't have all the answers, but I have a really great toolbox and resource list, and the SOAR TA Center, they do everything. So, and then the other piece is, if you do work at an agency where you have that relationship with your primary health center or the individual's doctor, so like my connection, if you can get that medical summary signed by a licensed practitioner of the healing arts, so a person that is licensed, that then is entered into medical evidence and it is weighted more by Social Security. And submitting a quality review, why would you submit an application that's not qualified? Whatever. So the medical summary report, like I said, it's a letter written by a SOAR trained caseworker to the Social Security Administration or the Bureau of Disability Determination. So Social Security does that financial piece. The Bureau of Disability Determination does the medical review. And each state has its own department that does the disability medical piece. In Pennsylvania, it's called the Bureau of Disability Determination, but the rest of the country calls it the DDS, Disability Determination Services. So those are kind of used interchangeably. So just the medical summary describes that person's limitations and their functioning. It's supported by the medical evidence, but again, it also fills in those pieces that don't necessarily come through. You can also include things like direct quotes from a person if you talk to a person's family member, to get that history. That's all included in the medical summary report. Things that you observe as the caseworker, you can include that. So those are all really good pieces to add. And it also can take the place of this SSA 3373, which is the functional report. Sometimes if a person does not have that functioning evident in their medical records, BDD or the Bureau of Disability Determination will actually request that they go in and do a consultative exam. Does not have to be a part of the process. Does not have to be a part of the process. Oftentimes is. But if you are a SOAR caseworker and you are that person's representative, you can call Social Security and say, what else do you need? Because I don't want them to go see not their doctor and just a doctor that they don't know to do something that's difficult and is probably going to re-traumatize that person. So what do you need? What can I talk to their doctor about? Can we do this assessment with their doctor? And then you would submit that to Social Security in lieu of consultative exam. So the components of the medical summary report, we do have a template on the SOAR website, and it does kind of cover all those domains. And it's important to note that the substance use history, it's important, but what's more important is showing periods of sobriety when that person's disability still was affecting them. And so when we write the substance use history, we always include those pieces like so-and-so was, inpatient and still was experiencing symptoms to kind of show that, their disability is not substance use based. It still exists when they're not on substances. So this is that blue book listing that I was showing you about. I'm just checking time. This one is for bipolar specifically. And I underline this because I have another section of an MSR that we can go through and kind of see how it aligns. But this is all posted online. All the disorders that they accept are posted online in the blue book, and what would get somebody approved for Social Security. These are the components that they're going to look at whenever they're looking at a person's application. So in employment history, Ms. Carter's never been able to keep steady full-time employment. Throughout her life, she's held a number of different odd jobs. She began working when she was 17, performing CNA work. She reports a number of fast food jobs, such as McDonald's. She would cook the fries or clean the dining room. She would occasionally be asked to run the register, but would quickly be removed from those duties. She would make too many errors. They would often take money from her checks for those errors. Ms. Carter would oftentimes lose her job because of her depression. She would not be able to get out of bed to go to work in the morning and would be fired for no call, no show. She would isolate herself from people and not go into work. And according to case notes from the Real Recovery Network in July 2002, she worked for St. Elisa's Hospital, but quit after only a week due to personal situations. Ms. Carter has not been able to maintain full-time work because she's unable to learn and remember the new tasks of the job. The last position she held was at Mary's Restaurant in Mobile in January of 2003. She was fired after a couple weeks because she was unable to perform her duties. She could not remember the abbreviations that were required for the job. So again, you can see how this would not be included in somebody's medical history. And if we go back to here, we can note that we talked about sleep disturbance, decreased energy, difficulty concentrating or thinking. So we are actually filling in the gaps of her medical history to get her to this blue book listing. And another piece is the functional information that we ask you to complete. Ms. Carter requires daily assistance from a nurse practitioner to understand how to take her medications properly. Ms. Carter wants to comply with treatment protocol, but due to the severity of her mental illness, she's unable to understand, remember, or apply information. Her thoughts are sometimes scattered because she often does not understand how to follow simple and routine instructions. She often repeats questions that have just been asked. She loses focus and does not seem to remember answers to questions. When she was making notes of her treatment history, she wrote all over the sheet of paper in no particular order or spatial reasoning. Ms. Carter first lost her Section 8 housing because she did not attend her recertification appointment. I hear that a lot. Yeah. She did not follow basic procedures written down for her, which has led to her homelessness. She's been asked to leave homeless shelters because she's unable to follow curfews due to her confusion over the concept of time. I don't know that I would have wrote this. I probably would have tried to be more strength-based. I think it's a little but I think for the context of you're trying to hammer home about her functional limitations, maybe that's the best way to do it. I don't know. So that's kind of the review of the medical summary, the biggest component of the SOAR process. I can tell you that nationally, we have a 65% approval rate on initial application, and we've had over 4,000 decisions. Or that was just for 2024. Cumulatively, 65% approval rate and 60,000 cumulative approvals. So, pretty successful. For financial outcomes, this is like where you can kind of pull the purse strings of your government entities. The average Medicaid reimbursement for 2024 was $16,000. So the state was able to recoup $16,000 of uncompensated care. And then for that general assistance in PA, we don't have that, but things like TANF would qualify. Okay. They were able to get $2,600 back. How long do I have? 5 minutes? Okay. All right, Pennsylvania's top 10 state. We're going to roll through it. This is some information on the number of individuals that receive SSI in PA. So 325,000. Are you going to send these slides out?
Yeah.
Okay, cool. And then this is something that is good to look at. It's kind of people's real experiences of their application timeline. So when somebody says, I applied to Social Security 5 times and I haven't been approved and it's been 5 years, sometimes that really is their experience. So that initial application takes about 225 days to process. And in Pennsylvania, the average approval rate is 38% on initial application. And if you are at risk or experiencing homelessness, it's around 10 to 15% approval rate. So Pennsylvania is number 2 in outcomes. Last year we did have a 77% approval rate on initial application in 107 days. So 3 months. 3 months sounds a lot better than 8 months to likely be 9. And then last year we were able to put $900,000 back into the PA economy. Cumulatively, so since 2005, our approval rate is 90%. So if you don't have a 90% approval rate in an average of 107 days, I would highly consider you look at SOAR as a way to increase your service effectiveness. So in Pennsylvania, we need more SOAR. We have really strong programs in Philadelphia, in the suburbs in Philadelphia, and then also in Allegheny. We do have a program up in Warren County. And then all of those Orange Stars I actually visited this past year to do in-person community building days, so gaining buy-in. So you might hear about some new SOAR initiatives. We did just recently fund somebody in York, or York funded themselves. So some exciting stuff is going on. If there is not a SOAR caseworker in your area, we do have an applicant self-help guide, which can give an individual or a caseworker that's doesn't want to do the whole SOAR process the opportunity to kind of like look at the steps that a SOAR caseworker would take, and then put in a high-quality application to Social Security, and that's available on the SOAR TA website. And it's written at a level, I think maybe a 3rd grade level, so it's really accessible. The online course is free. It's available to anyone. It takes about 40 hours to complete, and you will walk through the entire process of submitting an actual disability claim or a mock disability claim. You'll use the forms that you'll use in the future for a real disability claim, and there's a practice case listed. There's 2 different practice cases, Colette and Mike, and there's 7 different sections to the class that cover everything from the application process to the work incentives that you can access afterwards. And SOAR is a community. The state team lead, that's me. The TA center, we are all here to support you. It's not like you just take the course and then you're on your own. I get every question under the sun about SSI, SSDI. I can help review your medical summary reports for quality and see what the likelihood of approval is, as long as it's redacted. And then also, we are trying to bring in more local leads to kind of lead SOAR at the community level, to kind of have the pulse on what's going on in your local area. So like I said, the training is around 20 hours. A typical application for SOAR takes around 20 to 40 hours, but the buy-in on the front end, putting in that 20 to 40 hour application is going to save you putting out all of those fires of somebody not having income, stealing toilet paper, not paying their rent. Those all add up. We just don't, think about them in the front end. And then also you get an outcome tracking application with SOAR to be able to monitor your effectiveness. It shows your approval rating. It's all de-identified, HIPAA compliant. And that takes about 3 minutes to log a person's outcome. One thing I did want to bring up here, in Miami-Dade, they did fund SOAR in their jail. And on 680 applications, 89% of them were approved in 45 days. And the recidivism dropped from 70% to 22% when compared to the year before. And it was demonstrated there was a $7 million savings to the state of Florida. So pitch that to your people. I will talk to them. And that's all. We're good. But here's my information. Feel free to reach out to me, and you'll get these slides somehow. So.
Are SOAR caseworkers typically community health workers or social workers, or what role?
So I think
we have
we have kind of a variety of both. It's done best when they're just dedicated SOAR caseworkers.
I see. So full-time caseworkers. What's the foundation that people generally have?
So we actually have a whole hiring and supervising section on the TA website to kind of look at. You really want to hire somebody with a strong writing background, since a lot of it's writing intensive. But the ability to the social work and community health, you can't have somebody that wants to sit in an office all day.
Right.
They have to go out and they have to be able to kind of pull that information where it's really difficult. So the MI comes into play. So a person with a background in social work is probably best, but it doesn't have to be a licensed person. It can just be somebody that really cares. I think if we can leverage the retirement community, I think they would be awesome at processing applications for individuals. So
It's really smart.
yeah, that's my spiel. If you have any questions, please reach out to me.
Thank you.
Thank you. I don't, but I can write.